So, okay, so now the attendees are started to join us. So we will wait a couple of minutes so everybody can join. And I can already told you that I'm really happy to host this webinar tonight. It's an EFIC webinar, and we will be discussing about neuropathic pain and postoperative pain treatment with our fantastic speakers today. And a lot of you have registered for this event. And of course, if you miss it, don't worry, it will be recorded and it will be put up on the Academy. And if you have any question, please write them down in the Q&A. You have a little box where you can write a question and we will be answer them by time. Super. So I think we can maybe have a quick round to introduce everybody. So I'm just going to go through the first person that I see on the screen. So Rianne, if you can introduce yourself.
Yeah, thank you. My name is Rianne van Boekel. I'm working as an assistant professor and the head nurse at the Radboud University Medical Center, the Department of Pain and Palliative Care in Nijmegen, in the Netherlands.
Sigurdur, could you introduce yourself?
Yes, thank you. I am an associate professor with the University of Iceland, Faculty of Nursing. And I'm also a head nurse of the pain clinic in the University Hospital here in Reykjavik, Iceland.
Yeah, thank you very much. Suzanne?
Hello, my name is Suzanne Pauwels. I'm working as a pain nurse in the Radboud University in Nijmegen, the Netherlands, doing acute pain, chronic pain, and neuromodulation.
Fantastic. Winfried?
Hello, my name is Winfried Meissner. I'm anesthesiologist by training and I'm head of the pain unit in Jena, University Hospital, Jena in Germany.
And of course, Nadine.
Hello, my name is Nadine Attal. I'm a neurologist by training. I'm a professor of therapeutics and pain medicine, responsible for a pain clinical center in Ambroise Paré near Boulogne, and also co-director of a research team directed by Didier Boissira.
Super. So thank you all. And I'm going to introduce quickly myself. I'm Lauriane Nalékos-Ropian. I'm scientific program coordinator at EFIC, and I'm usually the one sending a lot of emails to the speakers for the Congress or for the Academy. And so now we're starting to have a lot of people joining joining this event. And as I said a bit earlier, we are going to talk about neuropathic pain and postoperative pain treatments. And we ask you to review the presentation that were posted on the Academy or affiliated to this presentation. And if you have any questions, please write them down and we will be happy to answer them. So I don't know, all speakers, if you have already something that you would like to introduce or to discuss today, or should we ask your first question? Okay, so I'm going to ask you something. With regards to non-pharmacological and pharmacological intervention for postoperative pain management, are there inconsistency in clinical guidelines? And how can clinicians navigate this to provide effective pain management? And I'm sorry, someone is vacuuming next, so I'm going to shut down my microphone while you answer.
So maybe I should start with non-pharmacological issues. The thing with non-pharmacological issues that it's a bit difficult because we have such a wide variety of non-pharmacological interventions. And as I said in my talk, there is a great problem that we are lacking studies in this area for postoperative pain and other types of pain as well. So there might be some incongruencies with between guidelines, but well, what can I say? Some of these guidelines are not very specific on non-pharmacological methods, while others, like if we look at the guidelines from New Zealand and Australia, these are pretty, I would say, pretty easy to navigate for people. And also the American guidelines that are now there, or dated there from 2016, but there seems to be quite, there seems to be recommending the same things mainly, but some of them recommend cold while others do not recommend cold. But I would try to look at 2 or 3 guidelines, and we also have to consider what we can consider in the settings where we work. We also have maybe some procedures and policies in place for each hospital. So I think you should not look into only one guidelines, but maybe look around to help to see what is generally recommended.
Okay.
Yes, I can add to that. And I would like to stress that most non-pharmacological interventions are usually very easy to apply. They are not expensive, and they will always help in combination with the pharmacological treatment. So I would not be too hesitant to apply those interventions. And if I'm looking at the guidelines for pharmacological treatment, well, they should be built on all the same evidence. So you should expect them not to differentiate very much between the recommendations. But sometimes, well, you can see that in the pharmacological treatment, sometimes some guidelines are very specific, procedure specific, especially, of course, when you're looking at the prospect guidelines, which will help you a lot. And some other guidelines are just a little bit more general. But if I check them all, I did not find really a lot of disparities. There are some guidelines are very good at also asking the research questions. For example, the NICE guidelines, they really have a special tab also for where research is really lacking on some pharmacological treatment.
Yes, I would like to add 2 years ago, the German guidelines were published on a new version, and for the first time, some non-pharmacologic interventions were really recommended. For example, transcutaneous electric nerve stimulation has now a B recommendation, which is the second highest in a German guideline. And I completely agree to what has been. From my point of view, there's a couple of non-pharmacologic interventions which are not well known, underestimated, and for some of them, evidence is really, really good. Transcutaneous electric nerve stimulation is an example. There are more than 50 randomized controlled trials in acute pain showing a number needed to treat of 2.5. That means you have to treat only 2 to 3 patients to achieve a clinical meaningful pain reduction in one of these patients. And such a good number needed to treat is comparable to the majority of analgesics. And another advantage of TENS, of transcutaneous electric nerve stimulation, is it's patient-controlled analgesia. It's the patient has to do or can activate the device. And at our hospital, we run more TENS devices than PCA pumps. We have more than 20 TENS devices, and they are given to the patients by the nurses and collected again. And so we are really, I would really encourage everybody to try it. It's cheap. There are very few contraindications, if at all, and as I said, evidence is really good.
And because I have a background in neuroscience, but I don't work in an hospital. My question, which is a bit maybe of a naive one, when a new regulation arrives, how does it work? Does these either a department in each institution or on each hospital that is circulating this new regulation, or each practitioner have to look for and get this new information by themselves and put them in place?
If I answer that, I think it's mostly the institutions themselves that they have different ways of operating and different between countries, I guess, and also between hospitals. So it will be the some committee of the hospital or some person driving this area of treatment or something that would come in with the latest news on this. And I have to agree with you, Winfried, on the TENS, which is the highest, probably what is generally recommended in all guidelines and is easy to use. And nowadays you can buy TENS, what can I say? The TENS instrument, you can buy it yourself for a very decent amount of money if you want to use it at home as well.
Thank you very much for this insightful response. Another question would be to, how important is it to provide both pharmacological and non-pharmacological treatment option for the treatment of pain? And is it something that is widely used to have, like any clinician is going to use both, or someone would tend to go into more pharmacological to another one?
I think it's very important to use both, but I must say honestly, also in our own hospital, that the stress is mostly on pharmacological interventions, and so I think that there's need of a really a nice strategy for implementation to use far more non-pharmacological interventions. I'm not sure if the other speakers would agree with me, but.
Now, if I can add to that, I totally agree. And I think when we did a study in our hospital, we found that patients were reporting they were using all kinds of non-pharmacological methods, but these were rarely documented in their records. Yep. So I think many of these methods are methods that patients use at home already. They're familiar with them. And like you said, they are usually easy to, and many of them are easy to apply. And I think it's very important that the patient and maybe their family members can also engage in providing these interventions, which I think is very important. And if they can reduce the need for analgesics with their potential side effects, I think that's a great benefit. So a non-pharmacological method should definitely be part of the multimodal pain treatment.
Yes, and I think that it's also very important that our nurses, for example, that are working on the ward, that they have knowledge of these interventions and they are able to educate our patients on using them as well. Yeah.
And also, I think one of the barriers of using non-pharmacological methods has been shown in studies that nurses often lack support to use these methods. Mm-hmm. So people say, what are you using this for? Why don't you use medications or something instead? Or why are you using this? Is there any evidence for that? And stuff like that. So.
Yes, Suzanne?
Yes, I work as most of the time clinically or polyclinically, and I see a lot of patients in pain. And when you're in the hospital, you don't remember anymore what you can do non-pharmacologically. The people are used to do everything themselves, and now they're lying in the bed, and they have to remember to think with family or with us as pain experts to see what you can do, like listen to music or try other relaxation things in bed, massage the hand or the foot. That's what we normally advise.
Yeah, and other thing maybe to stress is that it's mostly beneficial, as Sigrid says, in combination with the pharmacological treatment. So Sometimes patients think, yeah, but when I'm listening to music, then maybe I will not get my medication. Well, that's of course not the case.
No, it's always and, yes,
And.
of course, yeah.
Yes, Nadine?
Well, I saw a question, a written question regarding neuropathic pain. You want me to respond now?
Yes, I'm just going to listen it. So it's a question from Abenam Gide. As you know, neuropathic pain is quite variable based on the cause. How do we select the best technique to use non-pharma for or pharma treatment?
Yes, thank you for this question. Well, first of all, I'd like to say that it's not that the neuropathic pain is not that variable depending on the cause. I would say that the symptoms and the mechanism are common to several causes, and that's very important because or else there wouldn't be any guidelines for neuropathic pain or questionnaires to screen for neuropathic pain. So there is, of course, very much variability, but this does not necessarily depend on the cause. This depends on the mechanisms, and the mechanisms are very complex and not completely linked to the cause, and that's very important for the treatment of neuropathic pain. So that's a first important message, I think. And the second, of course, yes, I listen to my colleagues and friends about the place of non-pharmacological treatments in the management of acute postoperative pain, and this is also very true for neuropathic pain. I mean, a few years ago, even a decade ago, we would have focused mainly on drug therapy, and we now more and more emphasize, even in the guidelines, the place of non-pharmacological treatments in the management of neuropathic pain. For instance, with Xavier Moisset and a French group, we did again. I would say we updated the 2015 guidelines, which were done with Nana Finrup and myself and many others by the NUPSIG, and we updated them because in these guidelines, and I'm happy that it was mentioned by Winfried Messner as well, we put at the same time in the guidelines non-drug therapy and non-pharmacological therapy in neuropathic pain. And I think what is very important in these guidelines is what the difference was not necessarily the cause of pain, but it was the area of pain and whether it was peripheral or central, and that's very important. And if you have, for instance, a localized peripheral neuropathic pain, you may start with topical agents, and there are many we can discuss, and you also may start with TENS, so transcutaneous electrical nerve stimulation. But if you have central pain, such as, for instance, multiple sclerosis or very widespread pain or very extended pain, then you would consider other drugs such as psychotropic medications as first line. So this means that the place of drug therapy and non-drug therapy has to be balanced, and this is true not only for chronic nociplastic pain, for instance, or acute pain, but it is also truer and more important for neuropathic pain, for chronic neuropathic pain.
Yes, and I would really like to encourage everybody to do a pragmatic approach, specifically with non-pharmacologic interventions, because patients will tell you very soon if it helps or not. And that's what we do with TENS, that's what we do with a cold or with interventions like this. That's the nice thing. The risk is so low, and patients will immediately tell you if it's okay or not. And so we even encourage patients to, for example, when they use TENS, to try different locations of the electrodes, to try different modes of stimulation. And so they are involved, they get some responsibility. So I would really like to encourage everybody just to try it. That's, I think, one of the advantages of pharmacologic interventions.
Definitely. Yep.
Yeah, I fully agree. Actually, in the non-drug therapy, I think there are different types of, these can be classified. There are many psychosocial interventions, but there are also many techniques of, I would say, neuromodulation or neurostimulation. And these techniques encompass TENS, but we also now increasingly use, for instance, repetitive transcranial magnetic stimulation. And this is very interesting because also no side effect, or really nearly no side effects. So this is very interesting for many patients with neuropathic pain, for instance. And these now appear, at least in the French guidelines, in the algorithm, which is, I think, new and interesting.
Yeah, certainly.
Okay. Anyone want to sorry. Anyone have a comment, or otherwise I have another question for you. Okay. So actually, I'm going back to Winfried, because you started a bit. Could you perhaps reflect on your talk about the role of combining adjuvant and local anesthetic in postoperative pain management?
Yes, in my talk, I pointed out the importance or the potential additional efficacy of adding specific drugs to local anesthetics. I'm aware that not in all countries it's the duty of the nurses or the responsibility of the nurses to add drugs to such interventions, but I think everybody should know there are clear recommendations in case, for example, epidural block or block of a peripheral nerve is not deep enough or is not effective enough, that it's possible to add different types of drugs. I don't want to repeat my talk, but what we know meanwhile is that clonidine and also dexamethasone are quite effective, and the special thing with dexamethasone is that it is even prolonging the effect of peripheral blocks and epidural blocks if it's given systemically. So it's not necessary to to use the dexamethasone or to put it in the catheter, but there are data that it even if given systemically, it works. But from my practical experience, I think it's very important that before you do something like this, you should be sure that the catheter is in the right place. What we see again and again is that the concentration of local anesthetics is increased and co-analgesics are added, but at the end, it turns out the catheter is dislocated and is not anymore in the right place. So that's my practical recommendation. Always be sure that the catheter is still in the right place before you increase the dose or add local add co-analgesics when performing continuous nerve blocks.
And does anyone has a similar kind of advice or see something that is continually a mistake that is continually repeated in postoperative pain or neuropathic pain assessment? It's a really general question, really naive question.
Actually, in neuropathic pain, we don't use a lot of blocks. We use local anesthetics, but by topical anesthetics, which is different. And of course, these can be combined with systemic drugs, but we don't use much blocks because these are chronic pain. So the problem of blocks, anesthetic blockades in chronic pain is that they're a short duration. They can be very effective, but this is for short-term pain and not for long duration pain or chronic pain. But what we use a lot of local anesthetics and the form of topical agents, that's for sure. And it's really convenient particularly for elderly patients, because these can cover a relatively large area and they are really very, very safe and very well tolerated. So this is very interesting for postherpetic neuralgia, for instance, or post-traumatic post-surgical neuropathic pain, when the area of pain is very limited or delineated. In that case, it's really interesting to use these drugs first, which are drugs therapy, of course, but these drugs first before psychotropic agents or other types of therapies. So these notion of balancing or combining drugs is also very true for neuropathic pain, but the most there's no such data regarding the systemic and local. What we have is more and more data regarding combination therapy, which is a little bit different, combining several drugs, combining, for instance, antidepressants, antiepileptics. We have newer data about these with very high quality data. But the thing is, we very much combine also systemic drugs and topical agents, and that's what we do most of the case, because most of the patients do not respond to one unique therapy. They respond to a combination of therapies. But the only thing the most important point is that, of course, we have to do this on a rational basis and not all together, because there are now studies, as I said, so we have to be aware that we have to do this on a really rational basis and not combine, and there are some combinations which are not indicated as well. So this is really something which we can do in the clinic more and more.
Yeah. Well, if you're talking about the local anesthetic, maybe it's important to stress the use of wound infiltration. Because if I'm looking at my own country, this is not really new, but it's not yet used in every hospital. And I stressed it also in my talk, of course, but the evidence about the wound infiltration is very good. And it's more and more you can use this kind of technique instead, for example, epidurals. And I see Winfried, I see that you're agreeing with this. It has been one of the topics, of course, of the pain out study. So maybe that's good just to remember to use these techniques.
Yeah, I completely agree. And when we look on, let's say, under estimated areas or existing gaps, I think the field of wound infiltration has still, at least in the majority of countries, there's really room for improvement. It would be interesting to hear from our participants how free their countries, because I mean, it's a job of the surgeon. It's something we can recommend to do, but in the majority of cases, it's not done by anesthesiologists or by nurses, it's done by the surgeon. So I think it's a matter of communication. And again, in a German guideline, there is the highest recommendation for wound infiltration. And this is something, although it's written down and the surgical representatives have agreed to this recommendation, in reality, we know it's not really done in the majority of patients.
Yeah, there's still a lot of prejudices about the wound infiltration, for example, that the wound would not heal as good as if you would not use it. At least that is what we hear our surgeons sometimes say, which is not really evidence. And how is it in Iceland, Sigridur? Are you using the wound infiltration a lot?
I wouldn't say a lot. I think it depends pretty much on the surgeon. So
As well.
Yeah, I'm afraid it's not something that we generally do. Well, then the biggest room in the world is the room for improvement.
That sure is.
Okay. And otherwise, we received a question by Bernard van der Eyck. So hello, thank you for this meeting. Which is the place and way of administration of ketamine in chronic neuropathic pain?
Yes, thank you for this question. Ketamine is a drug which everybody knows about us because it's used in the context of acute postoperative pain and or perioperative pain, and of course also in neuropathic pain. And now it's more and more used as ketamine in depression, as you probably know. But regarding the place of neuroketamine in neuropathic pain, if you look at the guidelines, which we did some years ago, in which now in the process of being updated, not yet, but probably within a few years, ketamine does not appear because it's really a drug which has side effects, which is not easy to use, which has to be used by experted teams. Of course, in the hospital, you cannot use it anywhere. Of course, it needs monitoring. So it's a very complex drug to use. But we acknowledge the fact, and there are more and more now double-blind studies showing that there is indeed an effect at the acute phase. That's for sure. That's a short-term effect. There have been now more recently some studies, including studies made by French groups like Gisèle Piquerin, for instance, showing that ketamine may have some effect of beyond, of course, the half-life of the drug.
Oops.
That means that you cannot use this drug only for chronic pain. Acute exacerbations of pain, for instance. Do you hear me?
You froze a couple of times. I'm really sorry.
Oh, sorry. The network is not perfect. I'm sorry. Do you hear me now?
Mhm.
Yes, we do.
Okay. I can't listen to me. That to use ketamine in acute pain exacerbations because the duration of effect against placebo recent date is not 3.
I can't hear you. I don't know. Can you hear her? Nadine, perhaps you put off your camera, your video.
Yes.
Oh, sorry.
That may help.
Do you hear me now?
Yes,
you hear me
maybe close your camera while you
Okay.
answer, because it's sometimes a bit
sorry.
hectic and
Oh,
it's
yeah.
interesting. So we would like to hear you.
Okay. Do you hear me now?
It works, yes.
Oh, no, I will just say that ketamine is a drug which can be used in specific situations. It cannot be used as a first or second or even third line drug. It is for essentially for patients who have acute exacerbations of their chronic pain, for instance, because the duration of effect does not last more than 3 weeks, generally not 2 weeks. That has been found in double-blind studies. So it's a drug which has many advantages. It has anti-hyperalgesic properties, and so it can really facilitate sometimes the recovery of an acute pain exacerbation, but it is not a standalone drug, and it cannot be used as first or even second line for neuropathic pain patients. We do have data, but the data all show that there is a short-term effect of ketamine. It does not last for months, for instance. So this is the main drawback of ketamine. And of course, you probably know that it's an NMDA antagonist, and it has several side effects, including central side effects. So it's not that easy to use. But we still use it, for instance, in our center, in very select patients who, for instance, have, as I said, increased hyperalgesia, recent increase in hyperalgesia, or they have also problems with opioid-induced hyperalgesia. In that case, it can be interesting because it decrease the central sensitization, and so put the pain to the level which was before the acute aggravation or exacerbation of pain.
Thank you. This time we could listen to you the whole time, so that's great.
Thank you.
I just have one question, Nadine, because I remember from a different webinar on ketamine that there were some people from the UK that were prescribing ketamine in oral form. Is that the way that you do that in your country as well?
Oral form.
Mm-hmm.
No. Yeah. The ketamine is essentially used as an intravenous injection, sometimes subcutaneous, but mainly intravenous. Most of the studies, most of the evidence comes from intravenous injections. It can be, there are many protocols. Unfortunately, it's very heterogeneous. You have 2 hours infusion, you have 5 hours infusions, several days infusions. In the literature, it's very heterogeneous, and no multi-centered trial. You will not find any multi-centered trial, which is a problem, of course. But regarding oral ketamine, although it may be used, it has a very poor therapeutic ratio. It doesn't reach the blood, but it has a very small impact on the blood-brain barrier, and it has a small impact on pain itself. So that means that less than 1/10 of the patients who respond to IV ketamine respond to oral ketamine. So it's not a very good treatment orally. It's very good as intravenous, subcutaneous, and for short-term periods, and for acute, aggravation of pain, enhanced of pain.
Very good to stress that. Yes.
If
Or
I can
you can use it in palliative care as well, but that's different. In palliative care, have another use in palliative care. I was not speaking of palliative care here, just of chronic non-cancer pain or neuropathic non-cancer pain.
If I can add to just as a clinical experience, we sometimes use oral ketamine for patients that are in the hospital that have, it's mostly people with chronic pain before they were hospitalized, and they have very difficult pain after some surgery or during the hospitalization. So we recommend sometimes that we use like 50 milligrams of ketamine per mouth, and you should drink it with juice or something like that. And actually, we have our clinical experience. It's in some instances this is quite helpful, but definitely not all cases.
I don't know if Winfried has his experience in palliative care, but it's very different from the use in outside this specific context.
We use ketamine quite a lot, not only in palliative care, but also in difficult situations in very low doses for what we call bridging. So what we normally do is we add it specifically in cases where we have the feeling that patients have developed an intolerance towards opioids. And our impression is if we add a low dose ketamine to these existing opioid therapy, then for at least for a couple of days, we can achieve it results in a much better pain control. And for example, if a patient waits for block or radiation, and so we do or for surgery, then we do this also in intensive care. We do it a lot for a couple of days. But I agree, in chronic pain, we have limited experience. There was an interesting publication from France, from these 30 sites having summarized the experience with ketamine. And what was very interesting from my point of view was that these analyses resulted in the finding that the majority of analgesic effect was mediated by depression or by reduction of depression. And as you already said, from my point of view, it's a very interesting drug, specifically in the treatment of depression, and also in the idea that psychotherapy might work better if patients have received ketamine the day before, but this is another topic. So bottom line, we use it quite a lot in low dose, not so much in higher dose. And we still, at least I don't know who is the respondent, who not. It's difficult to predict.
When you say low dose, do you mean IV dose?
Yes, yeah. And these are doses 0.1 milligram per kilogram an hour. So really low doses. In these low doses, patients normally do not report any side effects. So this is a safe administration.
Do you use it as a continuous infusion or? Yeah,
we use it for, as I said, just an example, patient is waiting for surgery on Monday, and we have to bridge for the weekend high doses of opioids with limited efficacy, signs of tolerance. Then this is a typical case where we add ketamine for 2 days or 3 days, something like that.
I was just wondering, Suzanne, is there any contraindication for the use of ketamine, for example, or other pharmacological products in the management of pain diabetic neuropathy?
Yes, I was thinking we did a trial on the polyclinically with ketamine cream, so topically on the place where the neuropathic pain was, and I don't know if it's also used in other countries, but in Holland there was one pharmacy that made this crema, so it was not written by a normal general practitioner, but especially a trial in our hospital, but it didn't work that well, and especially it is very expensive, what already was meant. And people had to buy it themselves. It wasn't insured by the insurance. So that's where we used it at neuropathic pain.
And one of the hot topics that's come quite often is the role of cannabinoids in pain management. And I was wondering why it has been such a popular discussion recently. And how it's maybe used or not used in your specific field or the specific pain that you are studying or you're working with.
Well, ask it To me or? Oh.
For everybody, but Susan, yes, you can start.
Yeah. Yeah, we tried it also polyclinically. It isn't used clinically that I know, but
I will speak about that.
Yeah, polyclinically we used it, but it's there are a few people who has benefit of it, but not a lot of people. So we don't describe it so often anymore as comparing to years ago.
Yeah, and for clinical use in acute pain, for example, I covered it in my topic as well. There is really not a role for cannabis or cannabinoids on the effect of acute pain intensity, for example, or opiate sparing effect. There has been, I believe, this year a new systematic review and meta-analysis published, who stressed once again that for acute pain treatment there's no role for cannabis. But I think it's rather popular. At least it is in the Netherlands. It's really popular because people think that it will work for almost everything. And I think that in the discussion for the opioid epidemic, that people are looking for other means to treat pain. I think maybe this is something that has come into the minds of many people. Yeah.
Also because I think in Europe, in lots of different countries in Europe, the regulation has been a bit more laxive. For example, in France, at least, the CBD is a bit more tolerated, and you have more and more people that have access to it with a bit more ease. And I'm quite sure that you receive quite a lot of questions from your patients.
I said that it was really unclear why there were differences between the effect on chronic pain and the effect on acute pain. But maybe it has something to do with the changes in the endocannabinoid system. But maybe Nadine can say something about that.
Oh, yes, we have now. Yeah. We now have a large experience because we have started 2 years ago. We started the kind of experimentation. That's the way it is called. It's not a trial. It's not a clinical trial. I mean, there is no ethical committee. It's just a registry, I would say, which was lacking in our country compared to other countries such as Denmark or Israel or Canada. And so since over the past 2 years, we've been delivering directly to our patients several compounds, several cannabinoids in terms of dry flowers. So with various concentrations of CBD and THC, there were some with predominant THC, some with predominant CBD, and some with equivalents, like in Sativex, for instance. And we are also able to give some flowers, heated flowers for acute pain exacerbations, for instance. So we've been enrolling more than 700 patients for neuropathic pain only. It's not, as I said, it's not a clinical trial, it's a kind of a registry. And of course, this is quite different from what would be seen in clinical trials because there is no placebo. And we know that cannabinoids have a very high placebo effect. So in general, what we have been able to see is the feasibility is good. We can also deliver from pharmacies or from primary care physicians. That was the initial aim of this registry. And regarding, of course, the pain, I have delivered it to many patients with central pain in particular, but not only central, and pain paroxysm, multiple sclerosis in particular. And these patients generally benefit from this treatment. But that's one point. And so this is with the French Agency of Medicinal Products. Regarding CBD only, without THC, for the past 2 years, it is completely official. It is authorized in France for selling, but it's not a drug. It is a kind of a well-being drug. So you can buy it everywhere in the Galerie Lafayette if you wish. You will find it everywhere. It's not a drug. It's not a pharmaceutical drug. CBD only has no analgesic effect, to be honest. CBD only may have a slight anxiolytic effect, but no analgesic effect. And provided there is no more than 0.3% of THC, it can be sold freely. The only thing is, just for the people who are interested, you take CBD and you have very few THC, but if you have a problem of a car accident with only CBD, since there is tiny drops of THC in the CBD, you may be positive for the control of drugs. And this can be a problem because that's the problem for, for legal practice. That's just what I say to my patients. You have to be very careful when you drive, even with CBD only. It's not a drug, but it can be positive on drive control. So that's important. That's for the experimentation. But on the other hand, I know the clinical trials, and they are not all brilliant, I would say. And the last one is a Danish trial, which the group of Nana Finrup, it was published in E.G. Pain very recently. And if you look at this trial, it's a little bit depressing, maybe. It is not positive. But well, it doesn't mean that there's not a subgroup of patients who would benefit from cannabinoids. But thus far, the clinical trials are much less advantageous than the real life experience.
But in the real life experience, there's of course a selection of patients that already are prone to react to these drugs. Yes.
So a lot of placebo effects in the end. Okay.
Sure, there is an effect. I think there is one. The problem is it is not spectacular. It is not in all patients, and it's not on all symptoms of neuropathic pain. That is sure. For instance, there is an effect on spasticity, but this is less controversial because Sativex is available for spasticity-induced pain in multiple sclerosis in many European countries. But the effect on neuropathic pain per se is much less consistent. I would say from my experience and from some other trials, probably more on pain paroxysm, rather than on continuous or ongoing pain. But this is not completely demonstrated yet.
I would like to add that the situation in Germany is similar, but what we really see, we see from time to time, we see responders. And like ketamine, I'm not able to predict in advance who will respond, but we see in a very few patients, we see remarkable effects. Also in patients who say, now I'm able to reduce my opioids or reduce other analgesics. And we just treated such a very old lady with a low dose of THC, and she could completely finish her opioid treatment. But I recommend to try, but to stop the treatment if the goals are not achieved. And then and to discuss this in advance with the patient. And if this is done like we do it with opioids, we discuss the pros and cons, we do a try, and if goals which we discussed before we started treatment are not achieved, then we finish the treatment again. And then this is a non-responder, and then we know that this is not the right drug.
Yes, and I assume, Winfried, that you are speaking about patients with neuropathic pain, not acute postoperative pain, right?
Yes, exactly. So acute pain, we also did a study in acute pain with zero effect, and we participated in another study for acute cancer pain, which also was without any effect. I would not completely restrict it to neuropathic chronic pain. This lady I just mentioned had severe arthrosis and also scoliosis. So this was certainly a mixed pain, but chronic pain and not an acute pain situation.
Yes, in France, we have restricted to neuropathic pain because this has the pain for which you have the most data, but that doesn't mean it should be restricted to this type of pain. And in France, the experimentation also concerns non-pain situations such as epilepsy for some CBD only. High doses CBD may be used for epilepsy, and also spasticity, palliative care, and oncological symptoms. So it is not restricted to neuropathic pain. There are 5 indications.
So when you're talking about cannabis, are you then talking about drugs that are already tried and tested, or you're talking about medical cannabis?
Well, I'm talking of medical cannabis, but it's plants. That means it's plant extracts, and these are actually proposed by non-French firms, which, for instance, Canadian firms, directly sold to the agency, French agency, and this is the drugs we use now because we do not have our own delivery. We don't have any French company able yet to deliver these drugs. We also have the synthetic drug, which is, for instance, dronabinol, which is THC, oral pure THC. This is available in France, but it's not, it has no approval for pain. Actually, it's more for nausea and vomiting after chemotherapy. So it's not really approved for pain, but we can use it specifically for some patients. So there are several forms. There are the synthetic cannabinoids and the natural cannabinoids, I would say. And with the agency, French agency, we are now using the natural cannabinoids, so plant extracts.
So then you have a fixed amount of THC, or?
There are five, we have 5 different ratios, CBD predominant, THC predominant, you know, and even 2 ratios predominant and 1 ratio balanced. So that means one CBD, 1 THC, like in Sativex.
Okay, any other comments? No, I could see it was a hot topic also between you. We only have 5 minutes left. So for the attendees, if you have any last minute question, please put them in the question chat. Otherwise, I would like to ask something a bit more general. If there is any areas of basic pain science related to the physiology of pain that either require further exploration in your mind, or if there are areas that you are most excited about and why. So it can be about cannabinoid, it can be about TMS, it can be about ketamine, it can be about anything. Something that is maybe either you're looking forward more as studies or you are excited about and it's something that is positive for the field.
I'm not a basic scientist, but I'm very curious, and that's a topic to identify patients before the surgery, the ones that were prone to get acute postoperative pain or even chronic post-surgical pain. So I'm very curious about some kind of biomarkers or something next to the already known risk factors that we have, of course. And I know that there have been some studies about that, some genetic biomarkers, for example. And well, I'm very curious because and at the last day of the day after the EFIC conference, we are having a conference. Sorry, we have a webinar from the ISP, the EFIC, the sick acute pain, that is covering this topic. So that's my kind of interest.
Sigurdur, maybe you have something you are looking forward or you would like to see a bit more research for the clinical field?
Well, there are so many, I think there are so many questions and we still have to answer just simply regarding pain. There's so much we don't understand about pain yet. So in terms of, I would agree with Rian, I think this is a very interesting topic to research. And also how we can maybe, if there are any ways that we can, not only with acute pain, but also with like chronic pain, to try to identify those who seems to be more prone to getting severe pain that's difficult to treat when you don't know the cause of the pain.
Suzanne, anything on your side?
Yeah, I would. I think it's difficult because I'm not really a person who do a lot of research, but I would like to have more new medicines for chronic pain. I'm working now nearly 20 years in pain, and now the latest new medicine I've seen was the duloxetine, the Cymbalta, and that's already quite a few years ago. So yeah, hope for especially the chronic pain patients, more medicines that help them.
Winfried or Nadine, as you wish.
Well, from my point of view, I'm fascinated by the role of communication in pain management and in enhancing the effects of analgesics. So using the right words to form expectations of patients. And there is increasing research on this topic, not that much, but increasing. And I'm really fascinated by this type of research. Just currently, there was a study showing that the fact that a doctor talks to his or her patient in before pain stimulus is applied has an enormous effect on perception of pain. And I think we can substantially increase the effectiveness of our pain drugs when we use them in the right context. So in a broader range, it's about placebo and nocebo, and at least those parts which deal with expectation of patients can be mediated or can be shaped by us, by caregivers. And I think this is a very important part of pain research.
Thank you, Winfried. And Nadine?
We are now working a lot on, I discussed about this previously on neuromodulation techniques, and I also think this is a future for many of our patients, because this can be effective not only for neuropathic pain, but for nociplastic pain, fibromyalgia, for instance, or irritable bowel disease, and these represent also a highly unmet need. And I really believe that these techniques will be refined in the future, and we will be able to really achieve better results with a combination of drug therapy and these non-invasive brain neurostimulation techniques.
Super. Well, thank you all very much. We are getting at the end of this webinar. I think the discussion was really interesting, and I was happy to see that you could bounce each other with either feedback or comments. And I think our attendees, even if they didn't ask a lot of questions, they were really insightful, and they probably enjoyed a lot your discussion. And I would like to thank you again for all being there. And if you have any last comment, it's the time. Otherwise, I'm going to let you say goodbye to everyone. So do you want to have a last comment, or are you okay with that? Okay, super. So yes, I wish you all a good evening, and thank you all for being here. So the recording will be available on the academy, the EFIC Academy, in a couple of days. I think probably on Monday. And I wish you a great evening, and thank you again for being there.
Thank you. Bye-bye.
Thank you very much, and have a nice
Really
bye-bye.
Thank you very much.
Bye-bye.
Thank you very
Bye-bye.
much. Yes, bless.